Hello, DEF CON. So I'm Dr. Isabel Straw, and I'm going to be talking to you today about CIPHER, which is our project from the UC San Diego Center for Healthcare Cybersecurity on Cyberattack Impacts, patient harms, and emergency response. So I'm an emergency doctor by training, but now working in cybersecurity research. I'm very sad to not be there with you all in person, having an awesome time in Vegas, but I'll be following everything online and posting this on LinkedIn as well. So if you want to reach out to me after the talk, please do, and my contact details will be at the end. But to get started, the CIPHER platform. So the aim of this project was to start modelling healthcare cyber attacks as a kind of public health threat. And so we were looking at cyberattack impacts, patient harms, and then emergency response when these things occur. So that's what CIPHER stands for in this instance. And what we wanted to do was translate upstream technical failures that occur during healthcare cyber attacks into downstream patient harms and the kind of reality of what happens on the hospital shop floor in terms of injuries, diseases, and deaths. And so to do that, we wanted to build these data sets that we could use for modelling cyber attacks in this way and make sure that incident response is clinically grounded. And the reason to do this was firstly to try and minimise clinical surprise during attacks. So I'm sure lots of people in the audience know about these kind of various case studies where we've seen patient deaths and patient injuries during healthcare cyber attacks. So these kind of news articles are just a few examples of those. But we saw this case of infant death during a ransomware attack in the USA, which was settled last year. More recently, these are some news reports from cyber attacks on the NHS in the UK, which have now linked patient deaths to the periods of IT downtime. So the Sky News article is referring to one particular patient death, but there was over, I think, 150 safety incidents that they've already recorded. And that work is still kind of emerging. And throughout these case studies, when harms occur, we often hear clinicians talking about these issues of clinical surprise, so not being sure which patients are most at risk, who's most likely to get harmed, and then these issues where things obviously fall through the gaps. And then at the same time, in addition to helping the clinicians, we want to give the technical teams insights into which of the systems in the hospital are the most life critical. So if your radiology's gone down, your health record's gone down, your e-prescribing's gone down, wanting to be able to kind of hierarchically inform teams which of those are most likely to have a life-threatening impact on patient care. And so the reason for doing this as well is because we know that there's an increasing frequency of attacks occurring against healthcare infrastructure and that these attacks are getting more sophisticated. And while these attacks in the past have focused on sort of data theft, so data breaches to steal patient health records for whatever reason, monetary gain, etc. Increasingly, there's a shifting to what we call denial of patient care. So the American Hospital Association called these threat to life crimes because this disruption of patient care is obviously linked to adverse healthcare outcomes. So it's increasing frequency, increasing involvement of patient care disruptions. And so our aim was to try and model which patients are most at risk in these incidents and how we can better improve incident response. So to do that, here's a sneak preview of the resources that we'll be making accessible to everyone. But the first thing we wanted to do was collect data. And we wanted to have a database on patient harms known to have occurred from cyber attacks at hospitals around the world. And in order to start modelling this as a kind of public health impact, we looked at how these different patient level harms occurred at different time points. So we know that a hospital can go down for, say, a month, several weeks after an attack, and the harms you get in the first hour are obviously different to the harms that you're going to get at 4 weeks. So we looked at the time point these harms occurred, the clinical specialty that they occurred in, the technical system that was relevant. So if it was a delayed blood test, that was related to the laboratories, obviously, as opposed to imaging, etc. Details of the harms, and then we've also looked at the kind of medical interventions that you might need to protect against these harms. So the two data sets that make up our overall CIPHER database are drawn from two sources. The first is from academic data, and then the second is from social media data. And with the combination of those, we've got this overall database of over 300 cyber attack induced patient harms. And so I'm going to go through it in stages, as with each of those kind of data source evaluations that we did, we ended up developing different resources which now make up this platform that we're releasing. So first off, the academic data. Where to start as a researcher is always obviously a systematic review. So what we did first was we started doing a systematic literature review of published, peer-reviewed publications of hospital cyber attacks from around the world. And so we ended up with about 50 case studies of hospital ransomware. And in order to make this kind of accessible and interactive on the platform, we plotted these into these interactive hospital attacks map. So you can kind of scroll through, see where the attack occurred, click on it, and then kind of read details of the attack itself, but also the patient harms. And so I've included just a few here, which have different attack vectors, so different ways that the hackers obviously got into the hospital. Some of them you probably know about, so WannaCry at the bottom left there, which was quite a while ago now, but obviously known for its sort of global impact. Many of you might have heard of the Conti ransomware attacks in Ireland, so there's been a lot of papers that have come out since that attack detailing the effects on different clinical specialties, and that was via a phishing email. And then this one I've included in the top right here from Israel was interesting, as the attack vector this time was slightly different to those other two, so they exploited a vulnerability in the VPN, and these are becoming more common, obviously, VPNs, as we have people logging onto hospital systems remotely, etc. So that was the Deep Blue Magic ransomware. And then the two papers that aren't in a blue box are the kind of proof of concept papers that are also worth just mentioning, even though they weren't in our case study review. But these are the proof of concepts that show vulnerabilities in different medical devices which are hooked up to the hospital network, and so can obviously provide new routes of potential attacks. And I'll come on to that a bit more at the end. But overall, across these kind of 50 case studies, what we see is a diversity of attack vectors, and then also a diversity of technical dependencies. So some of these hospitals rely on e-prescribing, some of them don't, different comms pathways, etc. And that means that the way that the attack manifests in the hospital can be quite different. And so as a result of that, you have a diversity of patient harms that come out of each of these attacks. So to give you some examples of this, these are three examples of kind of patient harms that occurred, and they differed partly due to the parameters of the cyber attack and the way it took out different systems. So in the Conti ransomware in Ireland, we heard a lot about the impact on cancer patients as the radiotherapy and chemotherapy resources were taken out. And so your at-risk groups here, obviously those with kind of aggressive tumours, small cell lung cancer, etc. Whereas in the Synovis attack in 2024, this took out pathology services and really impacted transfusions. So this was an issue for patients with trauma, so maybe stabbing or shooting victims needing blood transfusions, or obstetric emergencies like C-sections. And then the last example here relating to the baby ransomware death. So this was related to issues with the remote telemetry on the labour wards. And so again, quite a different technical dependency that was affected. And so your at-risk patient groups here are your kind of neonates, complex pregnancies. So this is making the point that depending on the technical domain that goes down, you're going to have different clinical groups that need to be paid attention to. Okay, so that was the academic data. But the academic data really is only half the story, because as we know, peer-reviewed publications, if you've been through the very painful process of doing those, they're very slow, they take years, and there's big barriers potentially to clinicians also reporting harms during cyber attacks. So we know that it's not always encouraged, and also the actual reporting mechanisms that clinicians are supposed to use if they're digitally dependent and they go down, so like your adverse event reporting, then obviously you're going to have an issue with collecting that kind of data. So the other area we wanted to look at was social media data and kind of web data. And we've seen this used with other public health threats. So COVID, for instance, they used a lot of web mining of news reports and Twitter and various other kind of sources to complement the data sets that they had. So we did the same for cyber attacks. And we built these data mining algorithms, went through Reddit, over sort of 6,000 posts, looking for terms like deep blue magic ransomware, WannaCry, hack, etc. Doing this particularly on kind of support forums and healthcare staff forums to try and pick out these instances. And the first quote I've put there is from the paper that we'll be publishing based on all of this stuff. But firstly, we saw a different kind of specialty split when it came to the data sources. So in the academic data, there's a lot of information on the harms in emergency medicine and acute care. So things like the impact on stroke, heart attacks, etc. Whereas in social media data, we saw quite a different distribution. So patients with psychiatric complaints, particularly talking about issues with medication access and symptom deterioration. Neurology, so those were often chronic pain, migraine patients, headache patients who couldn't get their preventative care. And then obstetrics, we saw a lot of issues in which I'll come on to. And at the bottom here, there's two quotes. So the two groups we mainly saw chatting on social media was obviously patients and then staff. So the first quote there is from a patient talking about the impact of ransomware on their labour and the disruption to kind of birth plans, but also care on the labour wards. And then the second example there is from staff. So this is them talking about issues with cath labs going down and the need to transfer patients across facilities. And the graph you can see at the top there, this is from the platform, which we'll be releasing, where you can see these posts sort of over time. And we plotted points at which we knew that there were cyber attacks that occurred, and we could see the sort of spikes in activity then, as we would sort of expect. Don't mind me. So, social media data. So you can see that graph a little bit bigger there, where you can see kind of over time these different posts appearing. But we've also added this functionality to make it a searchable database so that you can search through the database depending on kind of your specialty of interest. So if, say, you're a paediatrician and you want to look at harms occurring that affect children, or psychiatry, and you know how you want to look for specific harms there. And then also you can look for kind of instances coming from patients or coming from staff. So we've got some examples there which you can't really see very clearly, so I'll just explain what a few of those show. But the first, the middle picture is a series of patient reports from the obstetric threads. So these were subreddits like baby bumps, arm miscarriage, some of the others there, I think women's health, and so quite a range of different kind of medical support forums. And here we saw patients talking about issues like getting their cervical smears, their pap smear results back, and those getting lost. We also saw patients reporting issues with getting access to care for their miscarriages, and then also at the bottom there, more issues again relating to care on the labour wards. And then secondly, so the kind of last image you can see there is from staff who are sharing their experiences. So we saw people talking about issues of transfers, hospital transfers, as I mentioned on the last slide. But then we also saw some issues which weren't present in the academic data. So for instance, staff on psychiatry units, so kind of high risk psych wards, talking about the CCTV going down, and then that giving them concerns about their safety and going to work. We also saw nurses talking about the air conditioning going out or not being able to control it, issues with the patient call alarms. So those are often sort of centralised to the main hub in the ward, so you can know, which bed is calling for help, and then having to do workarounds. So they would give the patients little bells to obviously ring instead, which is obviously a lot less effective, especially if the patient is compromised. So a whole range of patient and staff reported harms. So we got all this data, and we went through and we kind of clinically validated it. So as clinicians on our team, we went through and checked that the reports were relevant to particular specialties and made sure they were assigned to the right ones. Also looked to exclude kind of bots and any posts that were not relevant to our aims. And we ended up with over 300 of these patient level harms from the academic data and the social media data combined. So what we've then been doing with this is trying to turn it into a modelling approach where we can predict over time what patient events are likely to occur after the onset of a cyber attack. And this is what you can see in the cube here. So these 3D visualizations where we've plotted these safety incidents over time, firstly. So on the x-axis, you've got hour 1 to day 28. So we're looking at what happens in the immediate aftermath all the way up to the end of the month. And then you've got on the y-axis the different clinical specialties. So what's happening in orthopedics versus hematology, etc. And then on the z-axis are all the different technical systems. So for instance, the paging system goes down, that comes under communications. The imaging, the radiology is broken, obviously comes under imaging systems. So we have this way of visualizing the patient harms across these different axes, and then that allows us to manipulate the graph if you want to, say, focus on pediatrics, or if, say, you're the technical team and all that's gone down is your booking system, so you want to know which patient groups are most at risk. And then we've split these by whether they've been reported on social media or academic data. And when you scroll through these models, you can kind of click on them and go to the source information and see where these kind of harms are originating from. Okay, I'm not going to dive into all of the modelling because it's not as exciting as some of the other stuff, but just to kind of give you a flavour of what we're doing with this work and where we hope to go with it. We've been trying to next convert these kind of 3D visualizations into public health models of cyber clinical risk over time. So the first picture you can see that's kind of wiggling around and showing different age groups is from this paper that looked at excess deaths during the COVID pandemic. And I've included it here as it just shows the way that we can map other public health threats by different subgroups kind of over time, and using a metric on the y-axis for like a quantification of harm. So here they're looking at excess deaths, so mortality. And so what we wanted to do was something similar for cyber attacks. And so with our 3D cubes, we started assigning scores of kind of magnitude to each incident. So imagine all of the points on that graph, get a score of how severe they are in terms of morbidity or mortality. And then you transform that into these 2D plots, where on the y-axis you've got the seriousness of the harm, and then on the x-axis you've got time. And so we start plotting over time these kind of forecasts of patient safety incidents across different specialties. But as I said, I won't go into all of the models because they're potentially not as interesting, but also you'll be able to access them on the GitHub and on the website, and you can explore at your own leisure. So instead, I'll finish off by kind of talking about particular at-risk groups and the cyber attack sensitive conditions that we came across. And so what we saw when we combined the academic data and the social media data were these patient groups who kind of came up repeatedly as being at risk of harm. So some of them are in the table here, which is taken from our manuscript. But first off, sort of chronic conditions in chronic pain patients. So often when a cyber attack hits, the healthcare system switches to paper-based prescribing, and a lot of pharmacies won't accept paper-based scripts for things like opiates or kind of controlled drugs. And so the patients who were missing out on their medicines with that shift were chronic pain patients, a lot of those kind of being cancer patients as well, who came up repeatedly in the literature. A lot in kind of women's health and sexual health, which was quite interesting, and more of that was found on social media. So issues with access to birth control. I mentioned access to support for miscarriages earlier, and things like your fetal monitoring scans. So a lot of the kind of regular midwifery support got cancelled. Palliative care patients. So this was interesting because it was in the community. So outside of the hospital, there are often these widespread effects which weren't talked about as much in the academic papers that focused on the hospital. And in the community, we saw that patients who were at home, maybe on kind of end-of-life care or palliative treatment, were missing out on their comfort care with these issues with paper-based prescribing again. And trauma and critical care, so this has been talked about a bit more at DEF CON as well, but the issues for patients with those time-critical conditions, so major trauma, but also other emergency conditions like stroke, heart attacks. And then I thought this was quite interesting on the paediatric element. So issues related to newborn registration and safeguarding. So a lot of people saying they couldn't register new births or give new mothers birth certificates for their infants. And so that leading to kind of wider effects for those patients. Some more unanticipated findings. So what the Venn diagram here shows is that a lot of these incidents are related to these intersecting factors where you have the cyber attack parameters itself. How did the hackers get in? What do they take down? But then the hospital technical dependencies. So do they use digital prescribing, etc.? And then also the local patient population at the bottom there. So if your local population has a high amount of I would say maybe in like London, like stabbings and trauma, that's going to be very different to if you're obviously in an area that's more kind of rural with elderly patients with chronic conditions. So the disease burden is obviously relevant. And some of these other harms we saw, which were a bit more surprising. Fridges going down causes issues. So fridges in the hospital can be networked, and that's where you store a lot of your sort of blood products and things. And they have automated temperature controls, but if they go down, the products can defrost, and then those patients can't get access to their care. Issues related to the protocols and kind of intranet guidance going down, especially for more junior doctors, your residents who maybe aren't as familiar with protocols for more specialist conditions. Teleradiology, I'll come on to in the next slide actually. And then also issues related to the kind of normal ranges for certain blood tests going down. So for instance, what's considered normal and abnormal, and especially across different subgroups who maybe have adjusted thresholds, causing issues for some groups more than others. So obviously that has a health equity angle to it as well. Okay, just some further insights kind of that appeared on both academic and Reddit data. That's what the little icons at the bottom there show. First, impact on workforce. So anyone who has worked in a healthcare cyber attack, myself included, know that staff and fatigue is a real issue. And so we saw this in the academic data where hospitals took initiatives to try and bring in extra days off for staff who were having to shift to paper-based methods. But obviously this isn't going to be possible for all hospitals. And then on Reddit, we saw more colourful descriptions of these harms. So staff describing how the radiologist has been on for over 36 hours and issues like that. And obviously that's going to raise your risk of medical errors. And we see an example of those risks kind of manifest here. So in this academic data, we saw staff talking about teleradiology services going down. So if you take the X-ray in the hospital, but then you send it externally for a specialist to review who's somewhere else in the country, if that system goes down, then you don't have specialist imaging interpretation. And as we see in this second academic paper at the bottom here on the left, from Zhao and colleagues, they describe these exact issues. So having patients with missed injuries because the imaging hasn't been interpreted. And so here you're thinking about kind of your fracture patients, trauma patients, etc. And then again, more colourful language on Reddit pointing out that the C in CT stands for computerized, and how obviously imaging downtime causes massive issues in the hospital. Life-saving resources, so the kind of depletion of stocks in the hospital. I mentioned this with a few case studies earlier, but the impact on transfusion services we saw in the Synovis attack last year. So in the academic data, reports where the NHS had to go out and request donors from the UK population to donate blood because they couldn't cross-match people's blood for patients in the hospital. And so you have to rely on on O-type blood because it's safe for everybody. But obviously stocks of that ran out quite quickly. And then at the same time as the NHS requesting that, we also see in social media data that in other areas, other parts of the world, patients report that actually the outages themselves from computers can prevent the donations from being taken because of issues for patients turning up to those clinics. And then here, issues for patients needing transfers, a particular issue for rural hospitals where transfer times are longer. But we saw staff talking about C-sections often being transferred if they were considered too risky, so if someone had had previous cesareans. And then also issues in this causing worse outcomes for a lot of patients. So this is a paper taken from the academic literature, which is cited there, where this is the team at UC San Diego actually demonstrating that during these incidents of ransomware at neighbouring hospitals, you see a fall in the survival of patients with a favourable neurological outcome from cardiac arrests. So a patient has a cardiac arrest, brought back to life. Some of them will have varying degrees of kind of cognitive function after that. And during the cyber attack, those outcomes worsened significantly. And so a very interesting paper to read if you want to have a look at that. And then again, we see this kind of reinforced in social media data with staff talking about transferring critically ill children, diabetes being the one they're talking about there with DKA, so deteriorations in diabetic control, and then the cath labs as well. And the point I'll finish on, because I'm sure at DEF CON people are talking about medical devices. We all love talking about medical device cybersecurity. But we saw lots of instances across both data sources where impacts on medical devices obviously had a particular effect. And we can think of this in terms of software or hardware, or even sort of wider devices that might not be considered medical, but are just key to the hospital infrastructure. So in terms of software, issues with digital templating software was a particular problem. So this is where you have a software in the operating room that allows you to pick the right kind of implant effectively if you're fixing someone's fracture or something like that. I think the example they're giving here was for hip and knee arthroplasties. And when that goes down, then you have issues selecting the right resources for that patient. So you have a higher rate of kind of risks of post-operative complications. Chemotherapy platforms, so a lot of these can be kind of cloud-based platforms with a patient's particular chemotherapy regime. And when these go down and you can't get the infusion records for patients, this can really disrupt their cancer care. We also saw this with radiotherapy, so in the middle column there, linear accelerators being targeted, resulting in treatment kind of disruptions. And there were a lot of reports on social media focused on this, often from relatives saying that they're kind of very ill. Their very ill family member had their chemo and radiation cancelled. So obviously very devastating for those families. And then the last column here, making the point that it's not just medical devices. So it's quite interesting on social media data to see staff talking about the issues associated with all these other devices in the hospital going offline. So losing the air conditioning and how that affected ward environments. Again, the call lights going down and having to rely on things like bells and patients kind of shouting for the nurse's attention. So all sorts of different examples there. Okay, so I'm coming up to time. So this is the end. Just kind of a summary. So we've talked about CIPHER and the different patient level harms that can occur affected by these intersecting factors, and how social media data provides quite rich insights alongside academic data. I'm sure the question you all have now is how can you access it? So soon we're finalising and kind of polishing up the GitHub, which will have access to the data sets, obviously that I've talked about, and then kind of demo code with the models that we've built. And then we'll be releasing that at the October symposium. So follow the LinkedIn page for the centre if you want to see more information about that. But you can also reach out to me. My details are there. And then, we look forward to sharing more of this research with you. And I hope you all have a wonderful time at DEF CON this week. Okay.